Anybody? Remember to maintain the participation over everything. Even if you're wrong, we'll correct it. We'll fix it. So let's see. I'll read the question really fast. We'll get a good approach for this. So yes, we read the bottom question right here, the stem. Right? It says, which of the following is the most likely mechanism of action of the additional antibiotic on this bacteria? Okay, hold on. Mechanism of action, antibiotic. This is a subject that everybody here knows. I mean, we've gone through this so many times, right? Let's see. Let's see. So it says here a 67-year-old woman with congenital bicuspid aortic valve is admitted to the hospital because of a 2-day history of fever and chills. So that's not good. If someone has bicuspid aortic valve, now they're having fever and chills. Current medication seems to be lisinopril. Lisinopril, we understand this is an ACE inhibitor, guys. We know this. Temperature is 38 and pulse is 90. Respirations are 20. The BP is 110/70. So these vitals here, yeah, looking like an endocarditis, just being really biased in that sense. Yes. Cardiac examination shows 3 of 6 systolic murmur that is pathological. That is best heard over the second right intercostal space. Okay. Blood culture grows viridans. So they're giving it to you there, viridans. Viridans, which is susceptible to penicillin. In addition to penicillin, an antibiotic synergistic to penicillin is administered that may shorten the duration of the patient's drug treatment. So they want to know which of the following is the most likely mechanism of action of this antibiotic. Who remembers this, ladies and gentlemen? This is something that I repeat and regurgitate in almost all the drills over and over again. Aminoglycosides. Yes, 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 yes. Good, 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 good. Yes. Good. So the answer is B. And the reason why I regurgitate this, not because I just saw it on a free 120, is because it's on NBMEs. It's on a newer NBME. It's on UWorld. It's also on NBOS. Now, at that point, it's something that you need to know. If you see the same thing popping up in different Q banks, it becomes something that you just need to learn at this point. So, okay, let's go down towards this. Viridans. Viridans is a streptococci. Remember that streptococci is further differentiated by its hemolytic properties. You have alpha hemolytic, beta hemolytic, and gamma. So remember, for alpha, I have a mnemonic. I have VROPS instead of drops. VROPS. Viridans is resistant to optochin, but pneumoniae is sensitive. So I would say pneumoniae is sensitive to optochin, while viridans is resistant. Right? Alpha hemolytic. It will leave a green pigmentation. It'll leave a green pigmentation because it doesn't cause a complete hemolysis. It does not cause complete hemolysis. Now, beta hemolytic. Bar PS. Bacitration is agalactiae resistant, but pyogenes sensitive. Bacitration is agalactiae resistant, but pyogenes sensitive. Okay? So agalactiae is resistant to bacitration, and pyogenes here sensitive. All right. Now, guys, normally I would have said, hey, this is enough. This is great that you guys know this. This is awesome. You know, I would have said, that's enough for you guys. You guys are in good hands with this much information for the actual exam, but that's not the case anymore. Now they're adding new little features. So make sure you know the new little features. What do I mean with this? There's going to be something called CAMP. And no, it's not cyclic AMP. It's Christine, Atkins, Munich, Peterson test. So for this test, you're going to notice there's going to be 2 microorganisms that are going to be positive. So I'm going to put it right here so you guys can have this as well. CAMP, you guys have Strep agalactiae, right? And what is Strep agalactiae? Is this group A or group B strep? Who remembers? This is group B strep. This is group B strep. This is group B strep. I'm going to put it here. GBS. This is camp positive. Camp positive. Camp positive is just the ability to have a stronger hemolytic effect in the presence of Staph aureus. Now, I have to tell you guys, is Staph aureus alpha hemolytic or beta hemolytic? That's my question to you guys. Who remembers? It is beta hemolytic. So, yes, Staph aureus is beta hemolytic. That means it causes complete hemolysis. It causes complete hemolysis. I know it sounds crazy, but we have to add these little pieces of information. Now, for camp, we also have something else that's positive. For camp, we also have listeria. Listeria is also camp positive. It's camp positive. All right. Listeria has a very interesting type of toxin. It has a very interesting way of avoiding our phagocytosis. It has a toxin that's called listeriolysin O toxin. Listeriolysin O. This toxin allows it to escape phagocytosis. So when a macrophage can find listeria and it tries to extend its pseudopods in order to bring listeria towards the inside, listeriolysin has the ability to basically pop a hole in this macrophage and then release itself. So it can liberate itself. It escapes. It escapes using listeriolysin. Okay? That's a way to avoid phagocytosis. That's one of the key toxins that you can find, virulence factor, you want to call it, of listeria. All right. With that being said, camp, these are the two you have to remember. Now, there's also something else called PYR. PYR. PYR status. For PYR, you have two we need to remember. The two would be group A strep, which is Pyogenes. Yes, group A strep. There's also another one. It's also Enterococcus. Enterococcus. Group A strep is Pyogenes. I'll put it right next to it. Pyogenes. That's PYR status. So yeah, these are the additional type of identifying features that you guys should know. Camp, PYR. And remember that Staph aureus is beta hemolytic. Also remember that strep pneumo is soluble in bile. That's another one. That's all the information though. So yeah, don't be afraid. Don't feel like, oh my God, there's so much things I don't know. Don't feel like that because this is everything. I'm giving you the entire frame, the entire picture. This is soluble in bile. In bile. All right, that's all the features. That's about it. So you guys don't need to worry too much. But yes, here the answer was B. This is typical. This is the type of treatment that they give in endocarditis. They like to give beta-lactam drug mixed in with aminoglycoside. So aminoglycosides, you guys have to remember the mechanism of action. Does this inhibit initiation or does it inhibit elongation? Who remembers? Yes, so when we talk about growth in bile, yes, Enterococcus growth in bile. You'll see that Enterococcus has this, but so does Bovis. So let's be very clear. Yes, it stops initiation. You are right. So Blarina, let's see. What else is soluble in bile? all the gamma hemolytics? Both galactii, well, sorry, not galactii. They call it galacticus. That's strep bovis. Strep bovis, and also enterococcus. These are all soluble in bowel. Let me put this with a circle, green circle. If you guys want, I could screenshot this. You guys can use this. Yes. These are just the extra features, basically, that you guys would need to know. Here you go. Boom. Download, use. Definitely. This is the information that we got there. Now, just for extra credit, what was the toxin name? Who remembers the actual toxic name, toxin name that causes that beta hemolytic reaction? Who remembers that? Not coagulase. I'll show you what coagulase can do, guys. I'll show you a little image of what coagulase can do so we can understand this and get this. Not protein M. Protein M is the toxin responsible for mimicry. But no,
Oh,
yeah. I'm talking about the for rheumatic fever. Yes, definitely. I'm talking about just the hemolytic properties that this can have. This can actually cause hemolysis. This is gets super confusing, so I don't blame anybody, but I'll tell you what it actually is. These are the toxins that we'll find. I want to put it right here in the screen. These are the toxins that we find on Staph aureus. These are the Staph aureus types of toxins. So the beta hemolytic toxin that I'm referring to specifically will be this alpha toxin. I know it's confusing. It is super confusing. Why did the scientists do this? Why? Who did this? They're out for a vendetta against the students. They said, hey, you know what would be fun if we name alpha toxin, which causes beta hemolytic properties, which causes a complete hemolysis. Let's just name it alpha toxin, just to confuse everyone. All right. Yeah, that's just cruel. Yeah, this is in Staph aureus. Yes, this is in Staph aureus. Yeah, it's just another barrier, but probably just setting up barriers. Oh man. So all I'm telling you is that alpha toxin, alpha toxin causes beta hemolysis. Causes beta hemolysis. Beta hemolysis. That's what it does. So yes, that's why it can get so confusing. And remember this, coagulase causes this reaction, guys. Fibrinogen to fibrin. Fibrinogen to fibrin, that's coagulase. That does the same exact action as which clotting factor, guys? Which clotting factor is the same one doing this reaction? Thrombin. Thrombin. Yes. Remember thrombin. We talked about thrombin before. We said thrombin turns fibrinogen into fibrin. Well, guess what? Coagulase does the same. Coagulase is doing the same. Remember that? Yes, D dimer is a derivative. You end up making it automatically. Look, whenever you make it, you'll notice that you're going to make fibrin fragments. It just happens naturally. Yes. So look at what they put here, clotting factors. Clotting factors is what actually stimulates this, they say. Clotting factors is what stimulates this. Well, let's be very clear here. Factor 10 together with factor 5 form a complex and they stimulate prothrombin to become thrombin. Thrombin catalyze, well, yeah, thrombin will catalyze this reaction basically. You'll have fibrinogen turning into fibrin. Yes, and then you end up making some products, some fibrin products, and that is D dimer. Good, good, good. We understand this. We got this. But yes, looking at the mechanism of action, yes, we mentioned it inhibits initiation. It is the first type of initiation inhibitor. That's what we see here with aminoglycosides. Aminoglycosides. Yes, that's the 30S. Okay, has synergistic effect with beta lactam. So, what is the mechanism of action of C? Which drug are they referring to when they say C? Let's see if you guys can get this. Again, it's a semantic game. Yes, it's a semantic game, like Abner said before. Dapsone is correct as well. Interesting, good one. SMX and Dapsone. That's perfect. Definitely. Notice PABA. PABA. Okay. Now let's look at D. Inhibition of dihydrofolate reductase. We know this. This was already seen. This was mentioned. This was, yeah, good one, Pablo. Definitely. Sulfadiazine as well. D is TMP, right? Remember the actual inhibition of dihydrofolate reductase? TMP in prokaryotic cells. In humans, it's methotrexate. In malaria, it's proguanil. In toxoplasmosis, it's pyrimethamine. We know this already. We got this. Inhibition of DNA gyrase. Which one is that one, guys? Fluoroquinolones. Fluoroquinolones. Yes, yes, yes. Pablo, I know you meant to write sulfadiazine. Sulfadiazine instead of sulfosalicine. Yeah. Fluoroquinolones is correct, guys. And then A, binding to DNA dependent RNA polymerase. Which one is that one? Which one is that one? Rifampin. Rifampin. Yes. Yes, yes, yes. Perfect, perfect, perfect. Yes. This stops transcription. This is a transcription inhibitor. You guys remember when we were talking about this process, we were mentioning this process. We did mention one thing. We said that primers can be set. Primers can be set. Primers are set to specific DNA structure, let's say. And then you have DNA polymerase. DNA polymerase that can read primers and then can code going this way or going this way. This is different. This is different. They were talking about DNA dependent RNA polymerase. But I'm going to ask you guys a question. There's this one drug that inhibits DNA polymerase. We talked about this as well. This is an antiviral drug. You guys remember which drug this was? Acyclovir is correct. I hope everybody knows that. Acyclovir. Remember, we give false nucleotides in order to trick DNA polymerase. DNA polymerase will grab the false nucleotides and it will try to make a strand, but it ends up inhibiting itself because once you put that fake analog, it's going to lack a 3' end. Without that 3' end, you cannot continuously add more nucleotides. So therefore, the enzyme will inhibit. But it must undergo a process of phosphorylation. It must undergo a process of phosphorylation. So DNA polymerase, this is what we're doing here. We're giving a fake analog. Yes, the nucleosides. So be careful because this is not the same. This is the same mechanism, yes. Same little trick that we're doing with false decoys, giving fake nucleosides that lack the 3' end. They don't have the 3' end. We do the same trick with HIV drugs. But in HIV drugs, what enzyme are we inhibiting? We're not inhibiting DNA polymerase. We're inhibiting a different type of enzyme. Reverse transcriptase inhibitors. Yes. Yes, yes. And we're giving nucleosides. Which one isn't one that has nucleotides? Which one is the one drug, the nucleotide reverse transcriptase inhibitor? Tenofovir. Tenofovir is correct. Good one. Good one. Yes. So let's remember, guys. Let's remember that what I just said right now. I'm going to recap. Yes. Yes. They tend to mess with the kidney in general, some more than others. But I'm going to recap. What I just told you is that there's a way we could actually inhibit DNA polymerase, and it targets viral cells because it'll use a viral enzyme to activate itself. So it's going to specifically target viral cells. Here, basically, we're giving analogs, we're giving fake nucleosides. They get phosphorylated by actual uh, by actual cells that have the virus inside of them. Okay, they're going to undergo phosphorylation. Then they'll be active. Then you'll see that you'll be able to put this same type of nucleoside that lacks the 3' end, you'll put it in that chain. Once they fell for the trick, they cannot elongate that strand. That daughter strand cannot elongate. Therefore, they cannot replicate their virus. Hopefully, everyone understands. It's just a trick. We're giving them a fake nucleoside that's getting phosphorylated inside the cell. It's getting the phosphorylation, turning into a nucleotide. And then when this enzyme, DNA polymerase, tries to add it to that ongoing chain that it's creating, it can't. It can't continue anymore because we gave something that inhibits the 3' end. That's what happens with acyclovir or valcyclovir, these type of drugs. But I'm telling you, with HIV, it's the same trick with the HIV medications, the nucleotide reverse transcriptase inhibitors. It's the same technique. We're giving it nucleoside, getting it phosphorylated by that cell. But this nucleoside, once it gets phosphorylated, it turns into a nucleotide. But you'll notice that it doesn't have the 3' end. Same trick, except the enzyme that we're tricking here is different. The enzyme that we're tricking is reverse transcriptase. Oh, yes, definitely, definitely. They like to give protease inhibitors. They like to give also, this is part of the heart therapy. In the art therapy, you'll see that they'll give two different options. So, yeah, let me put this to you. This is important. It is on the first aid, actually. Usually, when you look at therapies, you'll see that they're not on the first aid too much because it doesn't really, like, it's not like a step two kind of test in that sort. So, you don't really see the actual therapy. But for this type of concept, it is. They tell you the art therapy that likes to get used in that sense. So I'm going to show you right here. This is it. Two NRTIs and an integrase inhibitor. That's what they like to do. Yes. Yes, they like to mix it up though. It's not anything, it's not concrete. You'll see that they'll switch up the drugs based on the specific patient. Let's take a look at this. Here you're seeing that anti-retroviral therapy. Yes, the Gravir, definitely, definitely. Two NRTIs and an integrase inhibitor. Look at that. Look at that. Regimen consists of 3 types of drugs to prevent resistance. That's their goal here. But then they like to switch it around. Yes, tenofovir and emtricitabine can be administered as a pre-exposure prophylaxis. That's another thing we have to take into consideration. Pre-exposure prophylaxis. So yes, this I would say is high yield just because you don't see this too much. Yeah, tenofovir and to pre-exposure. That is 100% true. You don't see this too much in this type of exam where they're asking what's the specific type of therapy, but they do here for this type of HIV, the art therapy, they call that. And you're seeing it here, anti-retroviral therapy. So this is what it consists of: 2 NRTIs and an integrase inhibitor. But remember, guys, this type of management changes because there's so many different types of side effects that are specific to the patient, right? The patient has like a messed up kidney. You wouldn't want to give something that can accumulate in the kidney. So therefore, you're going to switch up your drugs. So yes, remember this. This makes sense. So all I'm telling you guys, not to go too crazy, just remember this. Here on the left side, we're looking at drugs like acyclovir that will inhibit the DNA polymerase. Then on the right side, we're seeing drugs like NRTIs that inhibit reverse transcriptase. How? With the little trick, the trick of the fake 3' end. Trick of the fake 3' end. So remember that. Let me put this here. Let me put HIV. Let me give you guys a HIV here. And here I'll put uh H. Well, let me just put herpes. I was gonna put HSV, but let me just put herpes. Let me screenshot this and send it to you guys again. Look at the difference. Oh, I should write the name of the enzyme here. DNA polymerase. DNA polymerase. Bam. Bam, bam, bam. Now we understand. Now we got that in the bag. Put this here. Definitely. All right, let's continue. Let's continue. That was only one question. We dived really deep into these concepts, but we knew the answer here. Let's look at number two. Number two says, which of the following additional findings is most likely in this patient? A 12-year-old girl is brought to the physician because of a 2-month history of intermittent yellowing of the eyes and skin. Okay, kind of jaundice, right? Physical examination shows no abnormalities except for jaundice. Oh, okay. Her serum total bilirubin concentration is 3, with a direct component of 1. So, okay, we could naturally assume that indirect is elevated, indirect is 2, direct is 1, total is 3. So, when I think of indirect increase of bilirubin, naturally I like to think of some kind of hemolysis, just because that's something very common. So let's keep reading into it. Serum studies show haptoglobin concentration and AST and ALT activities are within normal reference ranges. Okay. There is no evidence of injury or exposure to toxins. Which of the following findings is most likely seen in this patient? Well, yeah, total should be 1. Paulo says UDP, it must be the liver. Any type of Gilbert. Right? Right. Let me see. What else? What else do you guys think in this sense? Increase in haptoglobin. Well, the haptoglobin you're seeing here is going to be normal reference ranges. Kind of took hemolysis out of the picture for me. Yeah, it kind of like took that hemolysis for me completely out of the picture. So then I have to think to myself, what here can cause increase in indirect bilirubin? I have to think to myself, okay, so Gilbert is uh, total absent, I think. Krigler jar is decreased activity. Gilbert or Krigler jar. All right. So if we're thinking Gilbert, Krigler jar, well, we're in luck because not all of them are here, right? B, because no exposure to toxin or injury. Dr. Carey says A. Krigler jar is more severe. Okay, Gilbert is stressor. Right. Does the patient have something that's stretching? Let's see. In this one, we're seeing, no, it doesn't mention it. 12-year-old girl, 2-month history. Yeah, they don't mention anything like that. But nevertheless, we have to look at this. Ineffective erythropoiesis. This here would lead to some kind of aplastic type of anemia, some kind of issue where you're not having the production of RBCs. Remember, if it's aplastic, if you do not have production of RBCs, okay, I'm not, let's see, Flavina says A, but it says intermittent. Ineffective erythropoiesis will not be the answer, could not be the answer, right? It could not be the answer. Would it make sense? All right, I think we're getting into agreements that it's A, right? Decreased activity of UDP glucuronidase. Let's see. D says increased serum alk phos activity. So increase
Is
in
it
serum.
Silbert? Because I'm very curious to know. It's mild, so I think it's Silbert.
Yeah, yeah. I would have to say here, guys, the pathophysiology of Gilbert, remember, it's going to be like some kind of partial deficiency that you have with UDP glucuronol transferase. It's a partial deficiency. It's not always going to manifest itself, but it will have a problem with converting the indirect into direct. So you wouldn't be able to do this efficiently. That's the problem there. So what you'll end up having is about 30 to 50% reduction. Yes. What you see here, it says for Krigler-Najjar type 2, it gives statin. So let's see. Let's talk about that. Definitely. Normally, Krigler-Najjar, well, normally, let's talk about Gilbert first. Normally, in Gilbert syndrome, one thing that we should see is that normally it's asymptomatic. You don't have any issue. But in moments of stress, just like we said, you're going to see that this enzyme activity, UDP glucuronidase transferase, will decrease of 30 to 50%, a 30 to a 50%. So it wouldn't really be able to work as well, which is why they gave you that proportion, the proportion of indirect and direct. They gave you like basically like what an increase in their sense. But nevertheless, with Gilbert, yes, well, depends on what type of Krigler jar. But yes, Krigler jar, you have type 1 and type 2. So with type 1, you have the absence, the complete absence of activity here. UDP, glucuronol transferase. It wouldn't be there. So that is severe, right? That is severe. Yeah, they die as babies. This is extremely severe. Now, with type 2, you do have some type of activity. There is some kind of enzyme activity still remaining. It is less severe than type 1, but you will have a lot of unconjugated bilirubin, just like this situation. You would have it just like in this situation, definitely. But it is consistent. It happens. Yeah, phenobarbital type. Yes, it does help. It does help. It will help in that sense. That is true. It will help in that sense. You give phenobarbital, definitely. But yeah, in type 2, they have milder type of jaundice. It will be mild. And they do have an increased risk of kernicterus, though. So, does anybody remember what do we do in a patient who has an extremely high amount of, let's say, indirect bilirubin at birth? And yes, right, Dr. Carey says lactulose follow says blue, light blue. Yes, I'll tell you guys. Here in this sense, if you see an extremely high amount of this indirect bilirubin, one thing, yes, phototherapy. Phototherapy is correct. Phototherapy is correct. Kernicterus is very, very dangerous because this type of bilirubin can start to affect the brain. It starts to linger and it starts to enter and invade tissue and it can affect the brain. It can affect the brain. So what do? We give this photo type of therapy. Phototherapy would create an isomer. It will take the same molecule and switch its components around. Basically create an isomer that will allow this to be excretable. That's what it does. But yes, what they end up doing normally is they give phenobarbital to fix the situation. And remember that you're only supposed to do this when it's very, very severe in that sense. So let's compare everything. Let's compare everything. First off, all three of these. So let's compare all three of them. Let's give a little comparison of all three. Krigler, Najjar, type 1, type 2, and then Gilbert's. Put it like this. One thing I can tell you is that they are all autosomal recessive. They're all autosomal recessive. I mean, we're talking about the activity of an enzyme here, right? An activity of an enzyme. Okay. So, in that sense, I can tell you that Gilbert, in moments of stress, will have 30 to 50% of functionality when it comes to this enzyme. We're all talking about the same enzyme. The enzyme that we're talking about is the UDP glucuronyl transferase. Yes. So in type 1, in Krigler-Najjar type 1, what's the issue here? Absence. Complete absence. 0%. 0%. Now in type 2, you'll see it has more severity. In type 2, you have about 10% that's actually functional. That's why it's such a big problem. So with Gilbert's, the elevation that you'll have is very mild. It's supposed to be mild. In this question, it kind of looks aggressive in this question, but it's supposed to be mild. With Krigler-Najjar, it's supposed to be increased by a lot. Increased by a lot. So it should be like in the 20s. That's a lot. That's a big difference than seeing this like in the threes or twos, like we saw in this question, into this range, right? Huge, huge different types. This year can elevate all the way to 20, which is wild. You can have 10 to 20, 5 to 20. It could go this way as well. But it's to this extreme. So you should be able to get your diagnosis just based on that. If you have to, if they're forcing you to, and they're not giving you all the data, you can just look at the bilirubin levels. There's no reason why it should go higher than 5. It should stay lower than 5. The gallstones, I'll tell you what, Mona, with the problem with the gallstones is that you still would have had conjugation. Conjugation would have happened, but you would have had a problem proceeding to release that conjugated bilirubin. It would have been stuck. But the hepatocytes would have been able to do this. Right? Yes. And yes, Blarina, technically speaking, if we want to get into the semantics, yeah, any one of these could have been correct. Imagine you're in this test and you're spending 3 minutes, 4 minutes thinking, is it Gilbert's or is it Krigler-Najjar? And you're there thinking, and you start to draw this table and you start to get deeper into thought. And then you just realize that they're not even asking you the diagnosis. This is what happens. I don't know. There's a strategy about covering your answers and then thinking of what the answer is. I never really liked that strategy. I never liked that strategy. Direct bilirubin is high in gallstone. Yes, yes, Dr. Carey. Direct bilirubin is high because there is activity of the hepatocytes. The hepatocytes are still able to conjugate. How about in sulfa drugs? Let's say a patient is using a sulfa drug and he is allergic to sulfa drugs, and now he's having hyperbilirubinemia. Will I expect a direct or an indirect? Who can tell me? Who can tell me? Indirect is correct, and I'll tell you why, though. Let's talk about why. It really wouldn't be more of a hemolysis. I'll tell you why. It's because of albumin. Albumin is supposed to be a carrier. Albumin is supposed to carry the indirect bilirubin into the hepatocyte. It's going to be an important carrier here. But when you're having sulfa drug, you're going to notice that there will be a dissociation of the albumin with the indirect bilirubin. There's a major dissociation going on there. So this indirect bilirubin has no chaperone. It has no albumin to make its way towards the inside. Let's see. Then also high calcium. Well, I'll tell you what, it's not the dissociation of everything to albumin when you have sulfa problems, but it is the indirect bilirubin, definitely. It is indirect bilirubin, definitely. Okay, I'll tell you that. So remember one thing, Amna. Whenever we are to digest our RBCs, whenever our RBCs have reached the point where they need to undergo digestion, remember you have those sinusoid areas of the liver, and you're supposed to be able to take RBC in order to digest this properly here at the level of the liver. So when you have hemolysis, you start to rip, you start to destroy RBCs. And yes, all these type of RBC products make it to the liver. They go in through the sinusoid area. And yes, you're ready to basically digest them, to break them down, to recycle it. And you're doing it. It's working properly. You do have your enzymes there doing it. But the actual material that you're bringing to this liver in order to recycle supersedes the enzyme reaction. The enzyme cannot keep up. The enzyme cannot keep up. Does that make sense? It's like the enzyme cannot keep up with all that RBC material that you have. That's the issue there. So you're having way too much. Yeah, they're overwhelmed. They're trying though. They are trying, but they just can't. They were not built. The system was not built. Uh, well, let's see. Let's see. Someone said high calcium. Yeah, I don't know. I don't know which one you're referring to, Pablo, but definitely that's what happens here with hemolysis. You're bringing too much product, way too much. It's all good. It's all good. Okay, it's gone. It vanished. Okay, we're good. We're good. We're still good. All right. So yes, hopefully everybody understands so far. So yeah, we're comparing all three of them. All I'm telling you is that the level of enzyme reaction stops. Now, bilirubin, we're seeing here, less than 5 is Gilbert's. If it's 5 to 20, automatically Krigler-Najjar. That's what you should be thinking, right? That should make sense. All right. Okay, okay. Yeah, I wonder what it was now. You know what? I'll check it out afterwards because I know, yeah, I'll have access to the chat. I mean, it does pop up, so we'll see. But okay, going back, going back. All right, so yeah, we got this, we got this, we understand this. This is what happens. And yes, with gallstones are seen in what condition? Oh yes, definitely. So gallstones are going to be seen in hemolysis as well. Yes, they do form. They're pigmented type of stones. We can say pigmented stones, we should say. They're going to be a lot darker. Yes, there's pigment stones, it's called. So what's the pathophysiology of this? Well, you'll notice that you have something called calcium. There's always calcium that's implemented with all these stones. There's always calcium is always the bad guy. Calcium bilirubinate is one of the major contributors to this. There's an excess of this when you have unconjugated bilirubin in the bile, and it starts to precipitate. It starts to get higher and higher, and it starts to harden up. It starts to accumulate. Anything with calcium, basically, you're always seeing it's calcium. Yeah, they are smaller. They are smaller, definitely. And yeah, the major risk for this is hemolytic type of disorders, things like hereditary spherocytosis, definitely. Anything like sickle cell, for example. Um, anything like anything that can cause hemolytic anemia, generally. Anything, thalassemias, let's say. If you end up having more and more hemolysis, calcium bilirubinate starts to accumulate. Yes, yes, also as well, autoimmune. Crohn's, Crohn's, I remember Crohn's has bleeding. It does, but it has a lot of melena. I remember melena. Yeah, I think with Crohn's, you're thinking calcium oxalate. Calcium oxalate. So yeah, let me just explain. In Crohn's, try to remember the concept that our stools, remember, Crohn's typically happens in the level of the ileum. Ileum is mainly implemented when it comes to Crohn's. Let's think about this. So our stools usually is loaded with a lot of fat, has a lot of fat all over it. But we're supposed to break down this fat. We're lucky enough that we're able to break down this fat. We have lipase, right? We also have CCK. CCK is able to cause contraction of the gallbladder and it releases bile acids, which are going to be able to emulsify the fats. That's what's supposed to happen. But in a patient, let's say, who is having um, Crohn's disease, Crohn's disease, they'll have issues here. You'll have issues breaking down your fat. This level of your GI tract will be disrupted. So you will have issues with malabsorption as well. You're going to see that will be evident. The problem is this though. In the level of the ileum, you're supposed to have calcium binding to oxalate. To oxalate. That's where they're supposed to bind. But instead, they're supposed to bind and they're supposed to be basically excreted without any problem. But instead, this calcium is now binding to all these fats. Calcium loves to bind to fat. Calcium loves to bind to fat, guys. It loves to bind to fat. Remember, this is the case in pancreas. You can have something called saponification. Saponification. Saponification occurs when calcium starts to bind to the fat. So let's keep this in mind. Calcium will bind to the fat, and then oxaloacetate now is free. So oxaloacetate will undergo reabsorption. Reabsorption. So it goes into our bloodstream straight up. Oxalate goes into our bloodstream. And then where does it end up? It ends up in the kidney, guys. It ends up in the kidney. Yes. And who does it find in his kidney? In this kidney, it finds his long lost friend, his great friend that he was supposed to bond with from the beginning. It finds calcium. Calcium. And then they start to bind together at this point. And this is where you do not want them to bind. Because once they bind at this level, now you're having calcium oxalate stones. This is the pathophysiology behind that. Okay. Which is completely different than the pathophysiology of pigment stones. In pigment stones, basically, you're going to have this right here. Calcium bilirubinate starts to form and then starts to conjugate, leads to pigment stones. What else? In Crohn's, you could also have a different type of fat. Which one? You end up having, different type of stone. Which other types of stone can you have? You can have calcium oxalate, which is the other one. Who remembers? Who remembers this one? Remember, ileum is what's damaged here. Well, not phosphate. I'll tell you what. If the ileum is damaged, ileum is very important because ileum is supposed to reabsorb what? B12. Okay, that's one thing. Yes. Fat. I'll tell you what. Bile salts. That's what we're looking for here specifically. It is supposed to also have the reabsorption of bile salts. You're supposed to reabsorb this consistently. This is a very important process because you can't really have all the cholesterol here, all the cholesterol becoming bile acids. You can't have all that happening, which is why we need to balance this out. We need to help this process by reabsorbing the bile acids. We reabsorb it and we help this process. Now, if you cannot reabsorb it, this would be unbalanced. You'll have more cholesterol than you do bile, and then you'll have precipitation of cholesterol, leading to cholesterol stones. Yes, this is the pathophysiology behind that. So, yes, this is an issue that you can have. This is malabsorption of bile salts, leading to cholesterol saturation. Yes. It's also Crohn's is associated not pigment, but it's associated with two things: calcium oxalate stones, calcium oxalate, and cholesterol stones. Calcium oxalate in the kidneys and cholesterol stones in the level of the gallbladder. Those are the two that it will be related with. Yes. Good. Those are the two. So two different mechanisms completely. Because the malabsorption will lead to calcium binding the stools, the fatty stools, and leaving oxidate free to reabsorb. Oxalate reabsorbs, goes to the kidneys, and then it binds calcium, leading to kidney stone. But we looked at this as well. We said also you can have malabsorption of bile salts. That will lead to cholesterol stones because cholesterols, they can't all become bile acid. You can't have that. You're supposed to help this process by basically increasing the balance. Okay? That makes sense. That makes sense. All right. Good, 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 good. Let's continue. So that was a rather engaging question. And yes, just to answer Mona for this with gallstones, remember you will have the conjugation. It will happen. It's just the fact that it's blocked, so it starts to accumulate, and then you'll have an increase in direct. Direct will be increased. All right, let's continue. Ooh, this one looks nice. This one looks nice. Which of the following types of drugs is most likely to produce the effects most similar to those in drug X? Hmm. I wonder what drug X does. So, okay, it says here during an experiment, drug X is added to a muscle bath containing a strip of guinea pig intestinal smooth muscle. Hmm. Okay. Agonists are added to the bath, and the resultant effects on the muscle tension are shown in the table. Okay. So, what are they telling me here? They're basically saying that they have drug X, they're putting this on a muscle, and as they're saying specifically, smooth muscle of the intestines. So, agonists are added to the bath, and now they're looking at the effect. So, they gave agonist and they gave drug X. So, first they have drug X, and they're comparing this. Okay. So, oh, thank you, Mona. So here, Pablo says, cholinesterase inhibitor, more acetylcholine to me afterwards. So yeah, you're seeing there's a higher level of acetylcholine here. So it says here, which of the following types of drugs is most likely to produce the effects most similar to drug X? So you're seeing an increase in acetylcholine, increase in acetylcholine. So who agrees with Pablo here? Yes. 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 Take a look at this. We have the presynaptic. We have the postsynaptic. They're giving me a drug. They're not talking about more engagement, which is awesome because that's great. They don't talk about the engagement. They're just talking about the acetylcholine. Look at how the acetylcholine is increased. Yeah, muscle tension after they're saying drug X. Okay, yes, yes, yes. No, no, there they are. They are. They're comparing the two. They're saying that acetylcholine, if you give acetylcholine now, acetylcholine is more effective. Yes, good, 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 Marianne. Yes, so that is the answer here. Nothing else could have been the answer. Honestly speaking, nothing else could have been the answer, right? Nothing else even close, actually. Let's move on. Let's move on. That made sense. That made sense. I don't think this warrants an explanation that much. This one made sense. Let's see. Let's see. Let's see. So I would rather let's do this one. Is Carolina still around? Carolina's still there. Good, 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 good. Organophosphates. Organophosphates, they do the same. Yes, yes, they do. Definitely. They will inhibit this. Yes. Neostigmine, pyridostigmine, physiostigmine. Yes. What happens if we have too much activity? What is the antidote of this? What if we have way too much activity of acetylcholinesterase? What can we do? Yes, 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 yes. Good, good, good. Atropine makes sense. Atropine makes sense. Okay, Carolina, here we go. Boom. Let's look at this one. Which of the following drugs was most likely prescribed to this patient? A 52-year-old woman begins pharmacotherapy after being diagnosed with a type 2 diabetes mellitus. She was diagnosed. 4 weeks later, her hepatic glucose output is decreased, and the target tissue glucose uptake and utilization are increased. Which of the following drugs was most likely prescribed? So let's be very clear. Let's be very clear. They're saying, right? A lot of people are saying C. A lot of people are saying C. Let's see. Let's see. Everyone agrees? C? Yes. Okay. That was quick. That was quick. That was pretty good. That was pretty good. Everybody knew in that sense what the answer was. Yes. Without reading. Yes. Definitely, definitely. That was good. Metformin. Metformin. Yes, metformin. Um, Metformin inhibits gluconeogenesis, right? It stops you from trying to make more glucose in that sense. Now you're trying to utilize as much glucose as you can from your dietary source. So metformin doesn't really give you the problems that patients would have, like hypoglycemia, right? It really wouldn't do this. But one thing I would also include to this is this: when you're giving metformin, we have to check what? What do we have to check when we're about to prescribe metformin? It can cause lactic acid. So we have to check, yes, the GFR of the kidney. We look at the creatinine in order to see how the patient is managing with the GFR. So I'm going to tell you, there's a couple of drugs that we need to check the GFR when we're going to give kidney medication. Let's be very clear. We're going to give, I'm sorry, I said kidney medication. I meant to say diabetic medication. There's going to be three that we need to check, mainly three. Who can remember? Sulfonylurea, SGLT2. Yes, good. You guys got it. SGLT2 inhibitors. These are the dapagliflozin, empagliflozin, right? Then you have your sulfonylureas as well. Sulfonylurea. Remember, sulfonylurea has two different types of generations. Well, it has two generations, yes, but it also has an analog. It has an analog as well. Different drug. It's an analog. Something called meglitinides. So let's talk about this. Let's understand this. And metformin as well. Let's put metformin here in the list. These are the three drugs. Metformin, SGLT2, and sulfonylureas. Now, why did I separate SGLT2 here? Check this concept out, guys. The reason why I'm so interested in SGLT2 and the actual GFR is because if I do not check the GFR, then this drug will lose efficacy. It wouldn't be as beneficial to the patient if it's not going into Bowman's capsule, if it's not entering to the PCT. It will not benefit the patient, right? So instead of us being concerned of side effects when it comes to SGLT2 inhibitors, we're actually, yes, we are concerned with efficacy, the drug actually working. It'll never make it to the PCT. Yeah, it's a waste of money, basically. You're giving your patient a drug that's not really reaching the target tissue. It's not able to reach the PCT. You guys remember SGLT2. Remember in the PCT, we have H gap. H is the concept that has to do with carbonic anhydrase. It has to do with the ability of water and carbon dioxide to become bicarb and hydrogen. That's the H. There's a big channel there, very responsible for the reabsorption of bicarb. There's a drug here that inhibits the carbonic anhydrase. What drug is this? Acetylsolamide. Acetylsolamide. There's renal tubular acidosis that's affected whenever you have damage of the PCT here. Which RTA is this? Who remembers? Yes, it is. It is also sulfa. RTA type 2. Correct. Correct. RTA type 1 was which one? Which one is damaged? What's the pathophys of RTA type 1? What cell in particular? The alpha intercalated cell. The alpha intercalated cell. Remember, that's the cell that's also having carbonic anhydrase activity. That's the cell responsible for taking water, CO2, basically turning it into carbonic acid and then turning it into hydrogen and chloride. I'm sorry, hydrogen and bicarb. But remember, it does exchange chloride for the reabsorption. It does exchange chloride for the reabsorption. So type 2, the urine is acid. Type 1, it is alkaline. Yes, in the beginning, type 1 is alkaline. That is true. That is true. Things start to change afterwards. But nevertheless, that is the situation. That makes sense. That does make sense. 100% acetylsolamide. That's what we do. That's what we understand here for this. Now, we're looking at glucose here. Glucose. This is inhibited by SGLT2. If you can't have proper GFR, then you will not have the drug reaching this channel. All right, there's a disease here with this amino acid channel. Who remembers when this amino acid channel is not functional? What kind of disease we have? Hartnups. Hartnups. Hartnups is a major problem with tryptophan. Tryptophan is a precursor for what? Serotonin is correct. It is a precursor of serotonin and niacin. Niacin, and that's what would give us our symptoms. Remember? Dermatitis, dementia, diarrhea, and death. And then we said P. Yes, pellagra. We said P. This is a phosphate channel. And this year, remember, this is all PTH. PTH will allow the trashing of phosphate, but vitamin D will allow the reabsorption. Vitamin D will allow the reabsorption. Good. That was just a little recap of HGAP. HGAP is a huge concept to understand. What was that? Which one? The P? This is a phosphate channel that's found on the PCT. And PTH, oh, the gap? Yeah, the gap stands for, so you have HGAP. It's a concept based on the channels that you'll find on the PCT. So if ever you have damage of the PCT, you can take all of this into consideration. You'll notice that you'll have amino aciduria, right? Remember, you'll have issues with reabsorption of glucose as well. All of this would be involved in a damage of PCT. Like there's a Fanconi issue that the patient can have with the kidneys. And you'll notice that you'll have the whole age gap manifesting itself. Actually, let me show you. It's on the first aid. So let me show you. In Fanconi, you'll notice same type of issue. Yeah, let me show you the facts. Hopefully, yeah, I remember the first aid does show you. It does tell you everything that's messed up with it. Yes. So check a look at Fanconi. Just Fanconi. I'm not going to jump on all of them, but look at this. Like, what are the manifestations of it? Check it out. Yeah, Fanconi syndrome. Let's be very clear. Not Fanconi anemia. That's different. Look, it says here, increase excretion of amino acid. That's the A from the age gap. Glucose. So you're having an increase in excretion of glucose. That's the G from the age gap. And then it says here bicarb. Yes, bicarb because of the H from the H gap. And then phosphorus. So that's what you're seeing here. You see that? That's how it connects. Anytime there's a problem with the PCT, HGAP will be implemented. It would basically be in trouble. And that's how you'll see why. That's the reason why. Instead of memorizing all that, just memorize age gap. It should all make sense in that sense. But they could also be selectively damaged with different types of pathological situations. Yeah, there's a glucose channel. You could also have oversaturation over 180. I remember number was over 180. When you have too much glucose making contact with this channel, this channel is not this channel that can just reabsorb all the glucose in the world. It does have a limit. It can oversaturate the channel, and then you'll have glucose found in the urine. But yes, 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 they can tell you, look, hereditary defects, Wilson's, um, glycogen storage disease. Yes, got it. Nice. VMAX. What about VMAX? What about VMAX? The glucose. Yes. It's like it reaches a point where it can no longer reabsorb. So, but instead of lingering, yeah, it gets kicked out. It gets kicked out. S play then. Yeah, it gets too saturated. It's over 180. Then it starts to leave the system in that way. So yeah, this is the things that we check for when it comes to creatinine and these type of drugs. Now, sulfonylurea, you're checking it out for the same reason we check out metformin, guys. Same reason. Why? Because sulfonylurea depends, a great deal of it is dependent. Well, not lactic acid. I'll tell you why. A great deal of sulfonylurea depends on the kidneys for excretion. So both metformin and sulfonylurea, let me just tell you, if you cannot excrete it, it will linger in your body for longer periods of time. And then the side effects that it can cause, it will cause. So, for example, metformin. We said metformin can lead to lactic acid. So, if you cannot excrete it because it's not being picked up by your kidney, then it's more prone to cause lactic acid, right? You'll basically have a metabolic acidosis. You'll have a lactic acid buildup. So, for metformin. Well, that's the thing. It's not that it's actually leading to much of a problem when it comes to the reabsorption. I'll tell you what it is. It's that it depends on the reabsorption. I'm sorry, it depends on the excretion. So let me be very clear. If you have metformin, it's supposed to be kicked out by the kidneys. If your kidneys are not functional, if it has an increase in creatinine, then you cannot kick it out. If you cannot kick it out, it'll cause lactic acidosis. So that's one issue that it can cause. Now, one thing I will actually mention that's kind of crazy is that metformin can interfere with vitamin B12. It interferes with the reabsorption of B12 in the gut. It interferes with absorption at the level of the gut. Definitely. So, yeah, this has to do. This is a problem that can actually be reversed. I know it's kind of weird. I know it sounds kind of weird to everybody, but if you don't have enough calcium, you're more prone to this. So the patient that has a decrease in calcium and he's taking metformin, he's more prone to causing this problem, to having a decreased absorption of B12. So guess what? If we supplement calcium to a patient who's taking metformin, we could decrease this effect. The decrease in this effect can actually be stimulated by actually giving calcium. So let's be very clear. Calcium. Let's understand this. There's a relationship between calcium and B12. So if you give calcium, well, first off, let me just start off like this. Metformin. Metformin can lead to decrease in B12 absorption. Now, they have found that if you can give calcium, you can administer calcium, this will mitigate this effect. It'll stop this effect from happening. It'll help this effect out. It'll solve it. So increased calcium can actually play an important role here, reversing this metformin effect. All right. So that works in that sense. So yes, yes, yes. Remember this. This is something else that's very important when it comes to metformin. So yes. All right. Let's continue though. Let's continue. Definitely metformin, lactic acidosis. But then when it comes to sulfonylureas, what are the side effects that we are concerned with when it comes to sulfonylureas? What can it cause? Okay, okay, we got some good answers here. Obesity. Yes, obesity is uncontrolled insulin, basically activating more and more of basically, and I'll tell you why. I'll tell you why. But let's see. Hypoglycemia, yes, hypoglycemia as well. So let's work with hypoglycemia and then let's work with the obesity part. So hypoglycemia, I like this answer a lot because hypoglycemia is linked to a very high yield fact. If any patient is on a beta blocker, and they are also having this sulfonylurea, let's say, yeah, metformin, yes, metformin doesn't really, yeah, it doesn't make your insulin de novo. It does help in that sense. It does. Yeah, yes, Mariam, that is correct. That's where I'm going at here. That's where I'm going at here with this one. I'm saying that hypoglycemia can be masked with beta blockers. So if a patient is taking some sulfonylurea, and the patient is also taking beta blockers, the sulfonylurea can provoke hypoglycemia. Hypoglycemia. But guess what? The beta blocker will mask this type of effect. It will mask the hypoglycemia. That way you won't show this at all. That can be a very serious issue because you wouldn't be able to tell that the patient is having this type of symptoms. That's very important. Now, when it comes to obesity, one thing that we do need to understand is that obesity itself, it would make perfect sense that insulin can cause this because insulin is anabolic. Insulin is anabolic. Now, let's recall one thing. When we look at the process of lipolysis, remember lipolysis? Lipolysis. What was the major contributor to lipolysis? What stimulates the breakdown of triglycerides? What stimulates the breakdown of triglycerides? Who remembers? There was one thing over everything that it's just a perfect answer here. Decreased in insulin. Decrease in insulin. Yes, the decrease in insulin will provoke an enzyme. And already I see people writing the enzyme. It's hormone sensitive lipase. So decreased insulin is one of the major factors here. This is how you provoke the breakdown of triglycerides. So let me put this here very clear for everybody. Your decrease in insulin, of course, there's other hormones as well that are involved. Hormones like glucagon, epinephrine, all these stress types of hormones, right? Epinephrine. But one thing that I'm going to put here is the decrease in insulin. Why am I putting this here as such a big thing? This is the one that a lot of test writers love because the decrease in insulin is actually stimulating hormone sensitive lipase. The more it decreases, the more it starts to stimulate this. So let's understand this. You'll see that this decrease here of insulin will stimulate more and more hormone sensitive lipase. Hormone sensitive lipase will be able to break down this triglyceride into glycerol and what else? And 3 units of fatty acids. 3 fatty acids. These 3 fatty acids must travel where? Who remembers? Where do they travel to? Yes, they have to travel to the liver. Yes, they have to travel to the liver. Once they make it into the liver, they have to then go into the mitochondria. Yes, with carnitine. That is true. They make their way into the mitochondria. Good. You guys are good. Inside the mitochondria, well, they need a car to get into the mitochondria. So they go in through the carnitine shuttle. That's how fatty acid does this. Fatty acid becomes acyl CoA, and then it goes into the inside. And then they go into the inside to do a process called beta oxidation. We understand this. Glycerol, on the other hand, and I'm going to be very clear here, glycerol, on the other hand, enters the liver, cytoplasm, and there's an enzyme that reacts here, guys. What's the enzyme? What is the enzyme that reacts here? This needs to become glycerol 3 phosphate. Glycerol 3 phosphate. I'm going to be very clear. This information is important here, this little step here. Because glycerol 3 phosphate needs to become DHAP. DHAP is a molecule that's highly, highly malleable. It can become glucose. This is the process of gluconeogenesis. This is the process of gluconeogenesis. Glycerol is very important because glycerol will cause gluconeogenesis in a patient who is in starvation mode. Now, if you accumulate too much glycerol inside the liver, guess what? Instead of causing gluconeogenesis, it can use the glycerol. It can run the Krebs cycle. It can use it to go into the TCA cycle. So let's make sure 100% we know what we're talking about here. There's an enzyme here. I'm going to give you the name of this enzyme. This enzyme name, remember this one? It's glycerol kinase. Glycerol kinase. It's phosphorylating the third carbon on this glycerol. And you'll see that it's going to create glycerol 3 phosphate. High yield point, guys, for biochem. Just remember this. Yes, definitely. Definitely. This is the fate of glycerol. This is the story of glycerol. This is what happens to glycerol. Fatty acids, on the other hand, they bind albumin here. They bind albumin. They bind albumin and they make their way into the liver. And then they become acyl CoA. Then they enter the mitochondria. They undergo beta oxidation and they become acetyl CoA. Acetyl CoA. Yes. Yes, definitely. Let me take an image of this and put this on the chat. This is the fate of all of this. We're understanding what's going on here. I said lipolysis. I said that lipolysis occurs when insulin is low, and then you have this. So what is even the point of me mentioning all this? What is even the point of me mentioning all this? The point is this. When you have increase in insulin, like you do with sulfonylurea, you would have an increase in insulin. Let's be very clear. Your insulin will be high. Guess what will not break down? Guess what will not break down? Lipids, lipids, lipids. Yeah, so check this out. Your fatty acids in the bloodstream, how would it be? Would it be increased or decreased? Fatty acids in the bloodstream. It'll be decreased. It'll be decreased. Think about it. Yes, because your triglycerides are staying as a unit. Triglycerides maintain itself as a unit. It maintains itself as a glycerol with 3 fatty acids. It's a unit. It's not getting broken apart. This is happening when you have an increase in insulin. When you have an increase in insulin, you cannot activate hormone sensitive lipase. Let's be very clear. Let me put this here. increase in insulin. So actually, let me put it to you even better. I'm just going to write here sulfonylureas because this is the effect of sulfonylureas. Sulfonylureas, sulfonylureas are basically inhibiting hormone sensitive lipase. How? By making more insulin. By making more insulin. Yes. So I can tell you, oh, how are the triglycerides going to be in the bloodstream? Well, they're going to be low because they're not going to break apart from this. You see what I mean? You'll see that the adipose tissue will basically start to build up. You'll have more. Yes, that does not mean atherosclerosis. It does not mean atherosclerosis in that sense. Remember that we had a difference. We had triglycerides and we had cholesterol. We were talking about this earlier in the month. We had I did like that class. Guys, just to be sure, I'm going to tell you I did like that class because that class was getting down to some kind of basic knowledge when it came to the idea of atherosclerosis. Yes. Yeah, we did mention that, Paulo. Yeah, that was a good class. You would have been there, Paulo. We were talking about triglycerides and the power of triglycerides versus cholesterol and how cholesterol can accumulate within the clathrin pits, how it can actually um, undergo a reaction with macrophages and form some type of foam cells, basically leading to the buildup of arteromas on the vessels, the pathophysiology of atherosclerosis. And then triglycerides, we separated them. And we talked about the difference between that and how they travel throughout the bloodstream. But we'll get to that again, guys. We'll get to that again. Yeah. So, would beta blockers then further the increase of insulin? So, let me tell you something about beta blockers and insulin. And this might be a little tricky for everybody, but I'll explain. Remember when we talk about the battle of the receptors? We always talk about the battle of the receptors. We talk about how there's receptors that control everything in that sense. And that is a good concept to know. You have to understand which receptors are controlling what. That's a great concept. But the number one thing that will detail everything when it comes to physiology, when it comes to physio, the number one thing will always be what dominates the stimulus of said um, molecule, of said hormone, of said peptide. For example, I'll give you guys an example. We can have insulin right here. We can have insulin here. Look, beta 2, increase insulin secretion. We can have all this nicely put out. Alpha 2, decrease secretion. But let me tell you guys something. If the patient has an increase in glucose, guess what will override all of this? Will the patient increase insulin or not? You see what I'm saying? It doesn't matter. It doesn't matter. It's going to respond to glucose. It responds mainly to glucose. That's what it cares about. That's the number one stimulus. If you're having a hyperglycemia, you can give beta blockers, but guess what? Would it obey the beta blockers? The primary stimulus will be glucose. Yes. Yes. The hyperglycemia will provoke the pancreas, will make the pancreas release this. Same idea goes for the supraadrenal glands. Supraadrenal glands. You'll notice that the number one thing when it comes to aldosterone is perfusion, right? If you lack perfusion, your aldosterone system would want to stimulate as much as it can, which is why you don't try in this sense. It's like, notice how diuretics can be a bit dangerous because if you give diuretics, you can provoke a decrease in volume and you could actually stimulate the aldosterone system. So it gets a little more tricky in that sense. So what else? I'll give you another example. ADH. ADH responds to the osmolarity of our uh, system. So let's see. It says here, so, okay, so serum glucose over the nervous system by GLUT2. Well, you realize one thing is that um, the pancreas is over, like it basically just mainly cares about the major stimulus. Like the major stimulus will override any other factor in that sense. There's many things that try to stimulate. Yeah, the diuretics can trigger RAS system just because of this, what we're talking about right now. As soon as you get that decrease in perfusion, RAS will stimulate. So be careful in that sense when it comes to understanding this. This can get a bit tricky, but if you recognize the primary stimulus, then a lot of it will make sense. GLUT2, guys, just to remind you guys, GLUT2, because I see a pop word down here about GLUT2. GLUT2 is very interesting because GLUT2 can be found in the pancreas, can be found in the liver. GLUT2 is bidirectional. It can receive glucose same way as well. It can get rid of glucose. That's one thing that is very interesting in that sense. Yeah, it's in the kidneys as well. Definitely, definitely, 100%. It's in the kidneys. It's in the kidneys as well. Yes. Um. Yes. You see it. Where else? I
I have a
remember.
question really quick before you go on.
Yeah.
I'm getting kind of like confused. Um, so metformin will increase insulin sensitivity, but it won't increase insulin, right?
Well, no, no. Uh, Um, no, it won't. In that sense, what it's doing, it's decreasing gluconeogenesis.
Okay. And then like beta blockers, they are blocking insulin secretion, and that's why you get the hypo, like it can cause hypoglycemia because you're not, I don't get that part.
Okay, so beta blockers, you tend to have certain type of symptoms that happen when you have a hypoglycemia. There tends to be certain types of symptoms that can occur on the patient, but these type of symptoms will be masked. It's like it's not a direct. I know what you're thinking. I think that you're thinking more of a direct activity that's going on with the insulin itself and the beta receptors. That's not really the case. It's more like imagine if something is causing you to have palpitations, but then I inhibit the palpitations. It's more like it's inhibiting our reaction to having low levels of glucose. Therefore, we don't notice that the patient has low levels of glucose. It's more in that sense. So I would put it like this. Yeah, let me show you the symptoms of hypoglycemia and show you how they mask it.
'Cause I've had questions on this, and like it's like I've memorized that. When I see it, I had like a few questions on that where it can cause hypoglycemia or like you would see hypoglycemia, but I never really understood that.
All right, well, I'll tell you one thing. When glucose levels get lower in the body, remember what ends up happening. When levels of glucose are low, then therefore insulin tends to drop. When insulin drops, we have activity of glucagon. Not only glucagon though, because now we're undergoing a tremendous amount of stress. We also activate cortisol and epinephrine, right? And these kind of hormones that we see here are very much sympathetic. This is part of the sympathetic system. So sympathetic activity now starts to get activated. Now here comes the issue. If we give beta blockers, guess what we are blocking? The sympathetic activity. So we're going to be blocking things like what epinephrine would do. Yeah, the sympathetic reaction is going to get blocked. So here, for example, you'll be blunting the types of symptoms that a patient should have. So what should a patient have? If epinephrine is high, remember that epinephrine likes to bind to beta receptors. So if there's a beta 1, it's going to increase your chronotropic effect. Like we were talking about it earlier today. Heart rate will be increased. Inotropicity will be increased. That's what typically should happen when you have epinephrine binding beta 1. That should make sense. But if you give beta blockers, guess what? Now you will not have your tachycardia. Now you will not have your, um, let's say, your sympathetic activity. So, given these beta blockers that you're giving, especially if they're like the non-selective type that will bind both beta 1, beta 2, you'll end up inhibiting all these things. And yes, like Pablo is saying as well, Pablo did make good point here. He says here, um, livers and kidneys do gluconeogenesis. So think about this. When we are hypoglycemic, what else are we stimulating? We end up stimulating gluconeogenesis, let's say. But what are we doing? We have already inhibited. We have inhibited gluconeogenesis. With what? With metformin. So, in this sense, you're going to notice that the patient's reaction, the patient's survival reaction, let's say, all of this is going to have issues. Sweating is another one. Sweating is another one. Yeah, it's blunted completely. Sweating is part of the sympathetic activity, although it's stimulated by what? What stimulates sweating? Who remembers? It is a sympathetic reaction, but it's stimulated by acetylcholine. Acetylcholine, yes. Acetylcholine. That will also be part of the situation. So that is an issue there with sulfonylureas. Beta blockers will mask the hypoglycemic effect. It could go unrecognized. The patient is not responding to his hypoglycemia like he normally should. That's the issue there. Palpitations will be gone. Now, here's the trick. Will acetylcholine, will this activity be gone? Will the patient sweat? That's my question to you guys. Let's see if you guys really understand this. Will the patient sweat? Yes or no? It is sympathetic. We did say that. Yes, Mona. Good, good, good. You understand. The patient will still sweat. Although it is still sympathetic, it will still sweat. Why is this? Do you know why? Yes, good. Has nothing to do with the beta blockers at all. No activity, nothing to do with the beta blockers at all. So, yes, you can get away with this. You can get away with this. Does that make sense, everyone? Does everyone understand this?
Doctor, so what you meant is that the patients with beta blockers still are gonna be sweating?
Yes.
Oh, okay, okay. Thank you.
The patient will still sweat, and that's one of the big things you can tell the difference of. That's the only thing. Everything else is going to be blunted. Everything else will be completely blunted. And why is this? Why is this? Let me show you guys why this is the case and put it on the screen. You guys can see it. This is why. Look at the sweat glands. It stimulates M3. M3 is the stimulus here. You see that? M3. That is not having anything to do with beta blocker. Having nothing to do there, beta blocker.
So, I just have a quick question. Kind of got a little bit lost there.
Yeah.
So, if the patient is on beta blockers, right,
Yep.
and they have a hypoglycemia because they're given sulfonylureas, so they can still sweat.
Yes, that's the only symptom that it cannot mask.
Got it.
Beta blockers will
Got it.
mask everything else. They'll mask the palpitation, the tremors, all the sympathetic symptoms that the patient will have with hypoglycemia, except sweating, because sweating has to do with M3. It's a
Yes.
muscarinic type of activity, although it is still sympathetic.
Well, because it's in the sympathetic ganglion, but chain, whatever.
Yes.
But it's not the preganglionic. Yeah, I see that the first neuron is directed by the acetylcholine. Okay, got it.
Yeah, it's not basically responding to these kind of cholinergic type of receptors here. It's responding to M3.
I mean the second order, not the first order, second order.
Yeah.
Okay.
Yeah, this is the one that basically counts, this one here, because this is the one that's going to stimulate target tissue. Definitely.
Thank you.
Perfect. Perfect. That was a good concept there, guys. Good concept. High yield concept things coming at you for this exam. Definitely keep that up. Remember what we talked about today. Let's leave it here for today. We already have like about an hour and a half. Yes, definitely. Beta blockers will worsen hypoglycemia in any scenario. Forget about the idea of us giving sulfonylureas in any scenario. Because why? It turns off gluconeogenesis. That's also another issue that it can do. So beware. But yes, thank you, thank you, thank you, everyone. Thank you. Yeah, in beta blocker overdose, we give glucagon. Glucagon overrides the receptor, goes into the inside, stimulates. GS, yes, yes, yes. Good, good, good. Yes, this was a good class. This was a good class. We were flowing nicely. I like the energy on this class. Yeah, thank you, Pablo, for joining. Definitely. Thank you, Pablo, for joining. Yeah, we have good energy here in this class. I like this one. I like this one. Yes. Yes. La próxima clase, la misma hora en el mismo canal. Yes, yes, yes. Thank you, everyone. Thank you, everyone. I'll definitely upload the video immediately and I'll put it on the Patreon. You guys can rewatch this if any concepts got a little confusing. Watch it over. You definitely get it. All right. Definitely, definitely. I'll catch you guys tomorrow. Tomorrow we continue with the MBME. MBME has some weird questions. The next questions that are going to come up are a little bit weird, but we'll go through it. All right. Catch you guys next time. Thank you for joining me tonight and see you tomorrow.